1 in 8 patients treated for pneumonia doesn't actually have it. Once someone gets labeled with pneumonia, even if they don't have it, more than 90% of those patients are still treated with full courses of antibiotics and retain that diagnosis as they leave the hospital. The numbers are even higher for urinary tract infection. Diagnosis is actually a process that should change over time as new information comes in. What we also know is that often whatever diagnosis someone is initially given ends up being very sticky, and even when new information comes in, those aren't changed. And that means that people can get treatment that they don't need or fail to get the correct diagnosis because they were originally labeled with the wrong one. My goal in this program was to try to measure how often that diagnostic stickiness happens and to try to improve it so that we can improve the diagnostic process. Often that first sticky diagnosis is an infection of some sort. And the problem with that is that that means that a lot of people get antibiotics they don't need. And when people get antibiotics they don't need, antibiotic resistance grows. We really need to make sure that we're only using antibiotics when people really need them so that we have them to use when people do actually need them. We also wanted to understand how communication of uncertainty actually happened within teams. So with the help of the national academies, we were able to have a nurse that actually rounded with the team every day. And then at the end of it, to ask the doctors themselves, how confident are you about, or how certain are you about this diagnosis? And what we found is that across the board, clinicians said they were highly certain, that they had no uncertainty. But if you listen to their language, they actually were talking about some things that this test result didn't add up, or it could be something else. So there were some clues in there that they weren't 100% certain, but they weren't able to vocalize that. Most of our diagnostic tests aren't perfect. The art of medicine is actually putting together a lot of information to try to come up with our best guess of what's going on. But when new information comes in, we should update that guess. Because if you're a patient and you think your doctor is 100% certain, then you're gonna go with that. But if something else comes up, if you know that there's some uncertainty, you might give them more information. You might come back if something gets worse. And so the problem is not with uncertainty. The problem is that when we don't acknowledge uncertainty, we can't react to new information and update our diagnoses, and that leads to diagnostic error. Long term, what I really want to do is be able to get clinicians comfortable with talking about uncertainty, because I think until we are able to do that without hesitation, we're not going to be able to communicate that to our patients and improve the diagnostic process.